think endovascular therapy is exploring all sort of potential areas to expand treatment, to trying to make sure that we make it available to as many people as might benefit. That's taken several forms. It's expanded it in terms of time. It's expanded it in terms of taking it into people with more extensive strokes, more extensive ischemic damage. I think we'll see it expanding in the near future into smaller blood vessels that are occluded. That's technically much more demanding and somewhat riskier because very small vessels are quite delicate in the brain. And having these results will be potentially expanding it further. I think we'll also see some trials that expand a little bit further, even in terms of the time window, where we can go potentially up to 24 hours in some patients at the present time. I think increasingly we're getting some experience that suggests that there are some individuals even later than that who may still benefit. So I think these areas are being explored. There remains a big question about how we turn the trial results into operationally useful, appropriate guidance. And I think translating what worked in a trial into how we should implement this in healthcare systems is also a significant issue. And I think some implementation-focused studies are going to be increasingly necessary. We've seen the RACECAT trial in Catalonia, which looked at the logistics of taking people directly to a thrombectomy-capable centre versus going to a local hospital if that was closer, and coming up with the unexpected result that actually, on balance, you're better going to a local hospital in many cases. So I think these sort of implementation issues are going to be something that's in need of exploration and will be explored in future trials. So some trials pushing the boundaries to tell us patient groups who might benefit as a whole system, how best to organise that, how best to select patients, how to move them around. These are also significant challenges. I think the other bit is going to be adjunctive treatment. What combinations of treatment are best to optimise this? And I think that's probably the most exciting future. If you're looking at how we advance reperfusion of the brain as a whole, the question is going to be not just for whom this treatment works or that treatment works, but what combination. If we're going to optimize outcomes for everybody, are we using combinations of thrombolytic drugs and thrombectomy? If we're using these combinations, is the same dose of drug necessary for all people? Is it different for some people compared with others? Are there other drug treatments we should be giving to try and save more brain tissue? We know that you can open a blood vessel very successfully, but that doesn't translate into perfect outcomes. So 90% of the time you can open a big artery, but only 50% of people make an independent recovery. And certainly there's a lot of excitement about potential treatments that might extend the lifespan of brain cells that are ischemic and rescue other bits of the circulation beyond the big blood vessels we can visualize. So I think it's a very exciting time for stroke, and I think the optimal combination of all of these approaches is very much what we need to define, as well as the implementation.